Today we are going to go over a skill that you will use every day as a physician. That is the physical exam. It's going to tell you what's going on inside the body, and we're going to look at it from a physiologic perspective. So, let's learn how to use the stethoscope. To begin, we've worked through the cardiac cycle and we've started with the PV loop. We've divided up into the systolic and diastolic components. Systole begins with the closing of the AV valves, which are the mitral and the tricuspid valves. This is our first heart sound, or S1. As we move along the cycle, and as long as the heart was beating normally, then the next sound that we should hear is when the semilunar valves close. This gives us the second heart sound, or S2. You will learn and get the chance to have hands-on experience during your doctoring course to listen to the heart. Again, remembering your anatomy is crucial, and valves transmit their sounds to classic areas. The aortic valve and its pathologies are usually best heard to the patient's right sternal border at the second intercostal spot. The pulmonic valve is heard at the same level but on the patient's left sternal border. Remember that when you're looking at the patient, it's their left and not your left. To listen to the AV valve, move your stethoscope down to the fifth intercostal spot. At the lower left sternal border, you can best appreciate the tricuspid valve. And if we were going to listen for the mitral valve, then we would move over to the apex of the heart or the midclavicular area at the same fifth intercostal level. But what if you hear something other than the lub-dub when you listen to the patient's chest? There can be different pathologies that affect your heart valves. We call these abnormal sounds associated with these valves as murmurs. In trying to understand what the underlying pathology is, you need to know three things: where the murmur is best heard, when it is heard, and is it a systolic or diastolic murmur. So we know that the heart sounds come from our valves closing. Valves move either based on pressure differences or being physically tethered down during a contraction. If a valve didn't move like it wants to, meaning that it is too stiff, when we call that valve stenotic. A valve that is stenotic needs a high degree of pressure to open it up. So, pathologies associated with stenosis occur when the valve doesn't open, but it should. If a valve didn't close like it was supposed to, then we would say that that valve is leaky or incompetent. If we wanted to get fancy, then we would term it regurgitation. This is backflow across a valve to an area to where the blood came from. So, pathologies associated with regurgitation occur when the valve is open, but it should have been closed. So, when we plot the valve closures out over time, we see that S1 signals the beginning of systole, and S2 is the beginning of diastole. But we have to remember that there are actually two valves closing for each sound. The S1 sound, or when the AV valves are closing, is usually in sync. However, the S2 sound, or the semilunar valve's closure, can actually be separated in time. Before the S2, the right ventricle and left ventricle were contracting, emptying their chamber, but the two chambers aren't made the same. The right ventricle pumps blood to the pulmonic system, and that has a variable pressure. You will get much more during your pulmonary section, but when we breathe, it's based on a negative pressure system. We expand the chest during inhalation. We draw more blood into the right side of the heart. This increases the preload to the right ventricle. With the increased preload, it takes a longer time to empty that chamber, so the closure of that valve may happen a split second later. So, if we took a deep breath in, we should see a normal S1, but we may see an S2 split. This is normal, with the aortic valve closing just before the pulmonic valve. But if this split is exaggerated, then it can indicate that there is a problem with emptying the right ventricle. The next time that you listen to a heart, put your finger on a pulse, close your eyes, and listen. Imagine the valves opening and closing. Then open your eyes and look at the heart monitor and see what the ECG reads. This is the type of integration that you will need to learn and to master. Or if someone asks, just say, yeah, I heard a lub-dub, the ECG squiggly looks good, and the pulse is present. Again, thanks for watching and good luck with your studies.